Hi, my name is Dr. Anthony Ragusia, and I'm a clinical psychologist here at Evangelical. I'm going to be talking a little bit about suicide today, with the goal of helping you as an employee to learn a little bit more about how suicide happens and how hopefully it can be avoided. So to start with, many people find suicide hard to talk about. Lots of people do joke about it. Homer jokes about it. Pete Davidson joked about it on Saturday Night Live. But why do we joke? Maybe it's because suicide is so scary. Humans have a built-in fear of death, and the idea that we could take our own life or someone we care about could take their own life taps into that very deep, hardwired fear. And yet, most of us will think about it at some point in our lives. And most people know someone who has committed suicide or made an attempt. And maybe that's why suicide is scary, because for most of us, it's not something unimaginable. Maybe if we learn more about it, it won't be as scary. So here are some things maybe you know or don't know already about suicide. Suicide is the 10th leading cause of death in the United States. And for every person who completes suicide, there are about 25 unsuccessful suicide attempts. The national suicide rate has been increasing steadily and is now the highest it has been in nearly 30 years. One physician now commits suicide every day, the highest rate of any profession, and more than twice the rate of the general population. Nurses also commit suicide at rates above the national average. So why are health professionals at higher risk for suicide? Well, the answer is complicated because, of course, every suicide is unique and the result of a complex interaction of factors, including a person's personality, experiences, and possibly even genetics. So understanding the causes of any one person's suicide can be challenging. But we can generalize a bit and recognize that there are a cluster of unique stressors that health professionals face that may contribute to the decision to attempt suicide. Compassion fatigue is a term that's used to describe the stress that comes from caring deeply about the patients we work with. In our attempts to provide care, we may sacrifice our own emotional needs and become overly preoccupied with the needs of our patients. And because many of our patients will not ultimately have positive outcomes despite our best efforts, providers can become traumatized by the cumulative stress of seeing so many people suffer or die. This manifests in different ways for different people, including chronic sadness and depression, or feeling emotionally numb and indifferent to other people's suffering, to even feeling resentful against patients. Even a single particularly gruesome or emotionally taxing case can traumatize a provider, and psychological trauma is a risk factor for suicide. Whether intentionally or unintentionally, health professionals are often in a position where their actions or inactions can lead to patient suffering. Because health professionals are typically caring individuals by nature, this contradiction between the two facts, I am a caring person, and I am hurting people, creates a tension that some professionals cannot reconcile, and this emotional tension can become unbearable. Med students and hospital-based physicians and nurses are well known for having to endure long shifts with little sleep. Some are required to work in mixed shifts, which is known to play havoc with the brain's circadian rhythm system, and this causes a variety of stressors in the body. Lack of sleep is well understood as a cause of a great number of problems. It is one of the primary causes of medical errors, but it also leads to impaired judgment and emotional control, as well as a variety of signs of physiological stress that can make a person feel like they are unable to handle even minor stressors anymore. Lack of sleep can also serve to disinhibit a person and make them more likely to do riskier things they wouldn't otherwise do. One related factor that has been found predictive of tolerating the stresses of work is having a solid balance between work and other areas of life like family or hobbies that are also valued and prioritized. But when people work extremely long hours, that balance can be lost, leading a person to feel like what happens at work is the only thing that matters in life. If something bad happens at work, or if the person is afraid they may lose their job, then it may feel like the whole world is collapsing. Many health professionals feel like the pressure to treat as many patients as possible has grown enormously in recent decades. They feel like they're running on a treadmill that is going too fast for them to keep up, and may feel guilt for not being able to provide adequate care for patients. This stress may feel unescapable and unbearable. Leading to suicide is the perceived only way out. I often say that health professionals are great at providing help, but lousy at accepting it. This is a cultural norm that comes from being caring people and wanting to prioritize other needs above their own. But when taken to an extreme, this can lead professionals to present themselves as happy and otherwise well-adjusted when in fact they may be suffering deeply from problems and yet feel unable to ask for help. But there is a more malicious cultural norm that is sometimes seen where health professionals are actively discouraged from seeking help. This can manifest in supervisors or policies that punish providers for taking time off for self-care. In either case, to prevent suicide, it is important to feel like help is available. Now I want to talk about the difference between suicidal thoughts and actions. In one study, about 10 million adults reported serious thoughts of suicide, but only 2.8 million made a plan for how they would do it, and only half that number actually attempted suicide. So it is much more common for people to have thoughts about suicide that never lead to action. I should point out the interesting statistic in this graphic that shows a small number of people attempted suicide without ever making a plan, which highlights the reality that while suicide is usually planned in advance, sometimes it happens very spontaneously and impulsively, with little to no advanced planning. That does not mean that any one of us could suddenly decide to commit suicide at any given time without warning, and even for those people who didn't plan their attempt, there are typically warning signs and risk factors that an attempt could be a decision a person might make soon. Here's a really important point I want you all to remember. Suicide is almost always a permanent solution to a temporary problem. Usually, the crisis that precipitates an attempt is triggered by an event, and the emotional reaction to that event or series of events tends to intensify and peak within hours to days, but then subsides. Crises, regardless of the nature of that crisis, tend to resolve within a few weeks as we figure out how to adapt to or fix the problem that started the crisis. The highest risk period for suicide is actually toward the end of the peak of the crisis. So when people are hospitalized due to suicidality, the main goal of hospitalization is not necessarily treatment, it's actually time. It's about keeping a person safe until the crisis has resolved in some way. Here is a list of some common triggering events for suicide. Perhaps the most common is the loss of a cherished relationship, whether that is through divorce or death or a change in custody. Being fired from a job is another common triggering event. A sudden decline in health can lead people to feel very hopeless about the future and can lead to a fear that the end of their life will be full of pain and suffering that they would rather not bear. A financial crisis of some sort is a common triggering event, but sometimes there isn't one thing that happens. Rather, it's a series of smaller crises that add up over a short period of time before the person has a chance to adapt successfully. For healthcare professionals, as we talked about, feeling responsible for someone's death or suffering is a major cause of suicide. And again, that could be due to a single case or a series of cases over time. I want to shift toward talking about the personal risk factors for suicide beyond the triggering event or events. I want to be very clear. Because suicide is a relatively unusual behavior, and because thoughts of suicide usually do not lead to a suicide attempt, it is never possible to accurately predict who will commit suicide. We know a lot about risk factors, But keep in mind that a person can demonstrate a number of risk factors, yet never go on to attempt suicide. This first slide talks about risk factors that are the most general about a person, and thus are least likely to accurately predict suicide because so many people fall into these categories. The first is being female, as women are much more likely to attempt suicide than men. However, men tend to successfully complete suicide more than women because they tend to rely more on lethal means, like guns. White people, young people, older people, and people with a weak social support network, and people with a history of being abused, are all at slightly higher risk of suicide. This next slide zooms in a little more to describe risk factors that are a little more specific and granular than the factors in the last slide. I have selected a group of psychological risk factors that can be remembered using the mnemonic "is path warm." These include suicidal ideation, or thoughts about suicide; substance abuse, because people who abuse substances tend to be behaviorally disinhibited and more prone to impulsively act or engage in self-harm behaviors; feeling a lack of purpose in life; anger; feeling trapped; feeling hopeless; social withdrawal; anxiety; reckless, risk-taking behavior; and sudden mood changes. This cluster of factors together tends to be predictive of suicide, and the more of them that are present, the greater the risk. Now I'd like to talk about the most specific risk factors we have identified. A history of previous suicide attempts is one of the best predictors of suicide, perhaps not surprisingly so, but a person can have a history of attempts that spans a very long time before ever committing suicide, if ever. A history of attempts is a better predictor when there are other risk factors present. Another one of the best predictors is having access to the means of suicide, such as drugs or lethal medications, guns, knives, or a car. But access to means is also not very predictive in and of itself, because many people have access to means, yet never attempt suicide. But it becomes very predictive when other risk factors are present. Particularly, research has identified a cluster of psychological symptoms that tend to be present right before a person attempts suicide. It is referred unofficially as acute suicidal affective disorder, and is marked by a very rapid increase in suicidal intent over days or even hours. The person tends to feel socially alienated or personally alienated. This means that the person might endorse beliefs that, for example, everyone has failed me, or nobody understands me. Or they might feel like they are a burden to others, or a deep sense of self-loathing. These beliefs are combined with a belief that nothing can ever change, that other people are beyond changing or helping, and nothing about me is capable of changing. This hopelessness is in turn present along with 2 or more symptoms of hyperarousal, including agitation, irritability, nightmares, and insomnia. Again, people can present with many risk factors for suicide, but will never make an attempt, so this list cannot guarantee if someone will or will not attempt suicide. But the presence of the acute suicidal psychological state should be a clear warning that this person is at high risk for suicide, particularly when they also have the means to follow through. Some other specific signs that may or may not be present include behaviors like suddenly making a will or making efforts to give away prized possessions. The person will often talk about suicide, death, or feeling like they have no reason to live. Increasingly, people will post final messages on social media. Unfortunately, Because these social media posts are often ambiguous, friends and family aren't sure how to interpret them until after it's too late. I'd like to talk now about some myths about suicide that I think are common and need to be discredited. One is the idea that people who talk about wanting to die are manipulative and just trying to get attention. What I tell people is that they should always take talk about suicide seriously. Most people who commit suicide talk about it first. And yes, some people do make suicidal threats as an unhealthy way to be taken seriously or to get help. But the reality is that many people commit suicide by accident, by engaging in risky behaviors that disregard their own safety. These people may die without actually meaning to, which is another reason why talk about suicide should always be taken seriously. I should point out that this can look very different depending on the situation. Taking a person seriously may mean calling the police, or it may mean listening carefully to the person and showing respect for their concerns and feelings. Another myth is that you can't stop somebody who wants to kill themselves. This is technically true, but the reality is that most people who are seriously attempting suicide will stop if they are discouraged in some way from following through with their plan, and are unlikely to try again. You may have heard that an expensive net system was built around the Golden Gate Bridge because of the large number of people who committed suicide by jumping off that bridge. Some argued against it, saying that suicidal people will just find another way to do it. But research has concluded that the opposite is true, and people can be dissuaded from suicide by making it less easy to do it. This is because most people have very mixed feelings about wanting to die, and all it may take is some discouragement to push them in the direction of choosing not to die. Some people are afraid to ask someone if they're suicidal, for fear that bringing up the subject might make the person suicidal. The reality is that you won't make someone suicidal just by asking. It's one of the best ways to assess if someone is suicidal. And don't worry about upsetting someone by asking. They probably won't be offended, and you can only apologize later if they are still alive. So, it's best to err on the side of being clear and direct. At this point, you might be asking yourself what you can do for a person who is displaying risk factors for suicide. I suggest that first you have to determine whether this is a yellow light or red light situation. Yellow light situations are ones where you have reason to be concerned for a person's safety, but no immediate reason to believe that suicide is likely. In these situations, the person may be experiencing thoughts of suicide but has no plan or means. At these times, it is probably best that you try to be a supportive friend. Express that you care about the person and what happens to them, and then pay close attention over coming days or weeks to signs that the risk factors are growing, or if the person's behavior is becoming odd or concerning in other ways. You may want to try to activate the person's support system, because having a support system is one of the best insurances against suicide. This might include alerting other friends or family to your concerns so that they can reach out and help. It might look like alerting the person's pastor or mental health professional, or maybe encouraging the person to meet with a mental health professional. And once again, don't be afraid to directly ask the person whether they are thinking about harming themselves. In red light situations, the risk feels much higher. The person might have expressed intense thoughts of suicide and might be able to describe a plan for doing it. Multiple risk factors will likely be present, including the acute suicidal affect syndrome we discussed earlier. This situation should be treated more like an emergency, so your goal is more to try and increase the person's safety over the next few minutes or hours until other people can help. You might try to help the person come up with a safety plan, which is an agreement about what to do to stay safe that might include physically staying with the person and/or removing the means for suicide. You may also alert the person's support system so that others are aware of the emergency and can assist. Again, this might include friends, family, colleagues, or a mental health professional. In a red light situation, often the best action to take is calling 911. A police officer or ambulance will arrive to check on the person's safety, and if it appears that the person cannot stay safe on their own, they can be taken to a hospital for monitoring until it appears that they are safe. Until now, we've talked about helping others. But what about yourself? What if you are experiencing thoughts of suicide? First, I would remind you that suicide is almost always a permanent solution to a temporary problem. So if you can find a way to survive for a few weeks, you'll probably feel better. One way to do this is to write down a list of reasons why suicide shouldn't be an option for you. For example, because your faith strictly forbids it, or because of the effect your death would have on your friends and family for years to come, or because dying now would keep you from working toward any personal goals that you have for your life. It's important to do things that are stabilizing during a time of crisis and avoid doing things that are destabilizing. This might mean talking to friends or trusted supports and avoiding becoming socially isolated. It means staying active, doing things you enjoy and that make you feel healthy, especially sleeping. When you're suicidal, too much sleep is better than not enough. Even though you might feel extremely unhappy and as though nothing will get better, it is important to avoid emotionally numbing substances like alcohol or marijuana, or abusing prescription drugs. This will only serve to make the problem worse, even if there is some temporary relief. Avoid situations that are likely to make you even more upset. Avoid conflicts with other people if possible, to help you from not becoming socially alienated. Finally, consider meeting with a mental health professional. That person won't likely be able to fix all your problems, but it is a person who cares, who will support you through the crisis and may be able to help in other ways. As a psychologist for roughly 15 years, I have had patients who I know committed suicide, but only after they stopped coming to see me. I have never had a patient commit suicide while they were actively working with me. I think that speaks to the value of always having at least one caring person in your life. Finally, I want to review with you some additional resources you may find helpful if you have concerns about yourself, another employee, or someone else you know. Particularly if you have a concern about another employee at Evangelical, you may want to start by bringing it to the attention of human resources. They will help you to figure out what the best response should be given the circumstances, and what additional resources may need to be activated. Next, you can speak to any licensed mental health professional, preferably someone who is covered by your insurance. If you have Evangelical's health insurance, there are a large number of covered professionals across the county and beyond. I suggest you start by calling your insurance company or checking their website to identify covered professionals. But then, when you call, double-check with the professional to make sure that they are still contracted with your insurance company, as sometimes insurance companies are slow to remove providers who no longer take a certain insurance. Licensed professionals will discuss your concerns with you confidentially, but they may be required to alert emergency responders if they have reasonable suspicion that a person is at imminent risk of harming themselves or others. You may also access the Employee Assistance Program, which works similarly to regular insurance and will allow you to work with any mental health professional who participates in the program and receive a limited number of psychotherapy sessions for free with no copay. If you need additional help beyond those free sessions, you can probably continue working with the same professional, but you may then be responsible for deductibles or copays. And if you are looking for help but don't want to involve Evangelical or any of its programs, then you can always call the National Suicide Prevention Lifeline and talk to a live person. This program is designed to provide immediate support and stabilization, and then help you find a mental health professional if needed, not to provide ongoing or in-depth psychotherapy. So that's all for today. I hope that you learned something new, and I hope that in the future you'll be a little less scared to talk about suicide with others or to ask for help if you need it. Thanks for listening, and I look forward to seeing you around the hospital.